Good evening, everyone. I am Ada Afshin on behalf of IJCP. I warmly welcome to all our respected doctors and participants for today's digital live session. We are gathered here for a very important and clinically relevant discussion on the topic bleeding after birth, the new rules of prevention, early detection, and smart management. Postpartum bleeding continues to be one of the leading causes of maternal morbidity and mortality. With evolving guidelines, better diagnostic clarity, and smarter protocols, it has become essential for all clinicians to stay updated on the modern approach to prevention, early identification, and timely management. Today's session has been designed to bring exactly that clarity, confidence, and clinically actionable insights. So, I am introducing our host, Dr. Sangeeta Gupta, ma'am. With great pleasure, I now hand over the session to our moderator, Dr. Sangeeta, ma'am, to take the program forward. Ma'am, this is over to you. Thank you.
Thank you, Ada. Good evening and a very welcome to all our esteemed colleagues, senior faculty, practitioners, postgraduate students, midwives, nurses, program managers, and maternal health champions who have joined us today from every corner of the country. Dr. Madam Sharda Jain was supposed to moderate this session, but due to unavoidable circumstances, she cannot join us today. So I'll be moderating the session today. And as we all know, that PPH is the most important cause of maternal mortality. And we are here to, DGF is celebrating PPH Day today, and we'll be discussing about PPH. PPH, as I said, is the leading cause of maternal mortality. And what makes this burden particularly tragic is that a large proportion of these mortalities are preventable. FIGO has released a comprehensive set of 2025 recommendations that reflect the latest global evidence, emerging technologies, and lessons from low and middle income settings. The revised guidelines place a strong emphasis on universal prevention of every birthing woman, transition from visual estimation to quantification of blood loss, using shock index and physiological indicators instead of waiting for mm, clinical signs, refined uterotonic strategy, early time bound administration of tranexamic acid, and the structured PPH bundle. We will be discussing all these things point by point, and um, clear vision will be given to all the listeners. These guidelines are not merely for theoretical value. These guidelines are to be adopted in our labor room, our working place, and our day to day life. They are practical tools meant to strengthen our ability to prevent, diagnose, and treat PPH. Today, we have Dr. Poonam Goyal with us as our first speaker. Dr. Poonam Goyal is the head of IVF department, Max Vaishali Hospital. She is head of Obs and Gynae department of Panchil Hospital, as well as she is chairperson of Safe Motherhood Committee of Foxy. We have experts with us, Dr. Archana Verma. Dr. Archana Verma is past Foxy president and a consultant at Ghaziabad. Dr. Asmita Rathod. Dr. Asmita Rathod is past medical director of GTB Hospital. She's past HOD of MEMC and has got a long academic experience. I welcome Dr. Asmita. Presently, she is consultant at Manipal Hospital. Dr. Shashilata Kabra, known as PPH lady. Dr. Shashilata Kabra again has worked a lot as far as PPH and its prevention, its management, and new inventions are concerned in the management. So, Dr. Shashilata Kabra is senior consultant at DDU Hospital, Delhi. So, I welcome all my speakers and experts for today's webinar. Now, Dr. Poonam Goyal, she'll be
Okay.
discussing about the newer guidelines of PPH.
Thank you so much. Thank you so much, Dr. Sangeeta, for nice introduction and everything. So the stage is set. Let me share the screen in a minute to start the proceedings. Windows, yes, share. So I hope you can see my screen. Can you?
Yes, yes, yes.
Okay. Okay, so today we are celebrating the DGF PPH Day, and we need to go a long way when we speak of PPH. So I will be taking bleeding after birth. A little portion of this prevention, diagnosis, and treatment will be taken up later by Dr. Sangeeta herself. So in October 2023, WHO and several partners, they launched the roadmap to combat PPH between 2023 to 2030. 5th October 2025 is considered as the inaugural World PPH Day. The roadmaps call for all stakeholders to count, audit, and account for every woman who dies from PPH. It is reiterated with the aim of deriving the corrective actions so that we can prevent the preventable. So, global burden of PPH, as we all know, it remains the leading cause of maternal mortality globally. It accounts for nearly 25% of maternal deaths worldwide. 14 million women are affected annually by PPH. FIGO WHO call to action in 2025. They say that every facility should be ready, equipped, and should have trained staff. Every birth should receive uterotonic. Every woman should survive without preventable morbidity. The global roadmap is being prepared to end PPH deaths by 2030. So the key additions in 2025 update are that now they have given 15 consolidated recommendations for you to follow them. Then emphasis on Trenexa, timing of the injection, then uterotonics, their combinations, and the measurable outcomes. Inclusion of AI supported early warning and simulation based training is to be done by all the facilities for their staff. Our goal is to reduce the preventable deaths through standardized care. Early detection and rapid action can save life. All women should give birth in facilities with the capacity to treat PPH and administer IV medications. Referral protocols are to be standardized so that we don't lose women during the transfer. Now, what is the new definition of PPH? Now we say that blood loss of 300 ml or more than 300 ml with warning signals such as atonic uterus, heavy blood loss, large clots, or constant trickle of blood, change in the vital signs like pulse being more than 100, systolic BP less than 100, diastolic less than 60, so the shock index being more than 1, and blood loss of more than 500, even if the woman has no other concerning sign of shock or hemodynamic instability. So, main four causes of PPH we all know: tissue trauma, thrombin, and tone. The tone is main culprit in 70% of the cases, thrombin only in 1%, trauma 10%, and tissue accounts for 20%. Now, these 70% cases, the risk factors for that are large babies, previous PPH, long labor, shoulder dystocia, anemia, multiple pregnancy, then uterine fibroids. If the uterus does not contract and blood continues to pump into the uterus, then there is a problem. Then you need to monitor the woman closely. A uterus that is contracted can later become atonic. So you need to follow. Once you have seen that uterus has contracted, you cannot leave the patient for 2-3 hours. A full bladder can prevent the uterus becoming contracted. Now coming on to the tissue, 20% of cases, tissue left behind can cause atony and infection. Tissue includes retained placenta, amnion, blood clots, placenta previa, invasive placenta, etc. Then trauma, 10% of the cases, it includes lacerations, hematoma, uterine inversion, and rupture. The risk again, large babies, female genital mutilation, Episiotomy should not be given routinely. Now it is said that only if it is required, then only give. Just uh, don't as such give episiotomy in all, as used to be the practice in our country. Then augmented or obstructed labor, cesarean birth, vacuum or forceps birth. Then thrombin. This is coagulopathy. It accounts for 1% of cases. Severe preeclampsia, eclampsia, DIC, placental abruption, invasive placenta, history of coagulopathy, and sepsis. Now, coming on to care. In healthcare, respect and trust is the most important thing. Women should make their informed choices. They should feel safe and they should have privacy, feel cared for, and have a companion of her choice with them during the labor. The communication is very important. You should introduce yourself, inform about all concerns and options available to the patient, listen to her concerns carefully, and explain early if transfer is needed for advanced care, and always be honest in your communications. Then you should have emergency PPH cards, emergency PPH kit, trained team, regular drills and audits are a must. Functional referral pathways should be there. Blood and uterotonic supply should be ensured. Check daily if it is stocked and available. Now, during antenatal care, to prevent PPH, what we need to do, that we should prevent anemia. Give all women 60 milligram of elemental iron and 400 milligram of folic acid. Assess anemia by full blood count and address anemia by increasing the elemental iron if hemoglobin is less than 11 in first and third trimester, less than 10.5 in second trimester. Give 120 milligram of elemental iron a day. And if HB reaches more than 11, then it is good. Otherwise, consider IV iron before labor. If iron deficiency anemia is confirmed, oral iron is not tolerated, and rapid response is needed. In those patients, move for IV iron. Just like labor care guide, there is postpartum monitoring form now. Before birth, fill in any risk factors for PPH in that form. Assess and record all information, history, prior complications, and other risk factors. From birth onwards, check regularly for signs of PPH. Then postpartum monitoring, we should assess and record repeatedly. From the birth onwards, check regularly for signs of PPH. Record 4 times in first hour after birth to help diagnose PPH quickly. First assessment is to be done 15 minutes when placenta is delivered. In 15 minutes, even if the placenta is not delivered, then also you have to assess the patient in 15 minutes. This is the most critical time, the first 15 to 30 minutes when the PPH happens, and then every 30 minutes for next 2 hours. Then what should you check? Uterine tone, volume of blood loss and flow using the measurable tools. Then blood pressure of the patient, pulse of the patient. Your warning signs are pulse more than 100 and systolic BP less than 100 and diastolic less than 60, shock index more than 1. So first assessment is done once the placenta is delivered or 15 minutes after the birth, even if placenta is not delivered. Most critical, as most PPH happens in first 20 minutes after birth. Repeat every 15 minutes for first hour or until your patient is stable. Then what should you check? That is again uterine tone, volume, BP, pulse. Record 4 times in first hour to diagnose PPH quickly. This is the postpartum monitoring form which has been given by WHO and FIGO. You can download it from the WHO site and fill this form at the time of delivery and before delivery. Now, if PPH is there, start PPH bundle treatment. If blood loss is between 300 to 499 ml and other warning signs are there, if blood loss is more than 500 ml, even if there is no sign, preeclampsia, assess further and treat. If elevated BP and infection, you need to treat the infection and watch the patient for that. How accurate is the visual estimation of blood loss? Visual estimation of blood loss is completely unreliable. Diagnosis is guided by blood loss, rate of flow, uterine tone, and vital signs. A slow, constant trickle, a heavy flow, a large gush, blood clots can be dangerous. So, we should always use the tool to measure the amount of blood loss. Postpartum hemorrhage is about time to recognize, to act, and to escalate. Be vigilant for early warning signs. Dangerous bleeding can be a slow and steady stream or a large gush. Respond quickly if a woman has signs that PPH may follow, and early diagnosis is the first step. Prompt treatment with the PPH bundle is the next step. Warning signs we have already discussed, but to repeat, pulse rate, systolic BP, diastolic BP, then shock index. So shock index, if pulse more 110, systolic BP 100, so our shock index will be more than 1.1. Quick rule of thumb, if pulse is more than your systolic BP, that is an alarm for you. So to prevent infection, wash your hands and wear sterile gloves. Wear apron, mask, eye shield to protect yourself. Also to protect the baby, wear double gloves before birth and remove the soiled pair of gloves before clamping and cutting the cord. Properly dispose of or process the contaminated supplies as per the protocol, and always refer your patient in NASG garment so that she is saved. The NASG applies pressure to the lower part of the body and the abdomen. It forces the blood to the heart, lungs, and brain to prevent shock or stabilize a woman in shock. Anytime there is a delay in care transfer, there is a delay while you are waiting for the blood, you are waiting for the surgery or the procedures, then keep it on during all procedures and during transport and even during surgery. Remove as per protocol only when bleeding stops and the woman is stable. So apply the segments with strong pressure but allow breathing in the abdominal area. It's faster with two people applying, but only one should handle the segment 4, 5, 6 to avoid the over tightening. Leave the knees exposed for bending. For short women, you can fold 1 and 2 segment on itself and then start with the segment 2. Apply NSAG even if the woman is unconscious. NSAG stretches for checking the uterine tone and massage. It can remain on during vaginal procedure and toileting. Segment 4, you can slide whenever you need. Leave it on during surgery, but remove 4, 5, 6 whenever you are doing something abdominally. So every safe birth, a fulfilled dream, a silent prayer answered. Thank you so much.
Thank you, Dr. Poonam, for a very vivid description of the newer guidelines and the preparedness of the organization, the facility where the patient is going to deliver, so that all ready things are there with the man for the diagnosis and management of PPH. The questions and the answers and the opinion of the experts will be taken after my lecture, which is because both the lectures are interconnected and we will be
Yes,
overlapping in questions if I don't
absolutely.
discuss. So I'll be first discussing the prevention, diagnosis, and management of bleeding after birth. Thank you, Ada, for sharing my slides. Next, please. So we all know that the incidence of PPH after vaginal delivery is 2 to 4%. After cesarean section, it is 6%. And it is higher in rural areas, it is approximately 12%. The maternal death, which earlier used to be 38% because of PPH, now because of hospital deliveries and institutional deliveries, the mortality has decreased to 19.9%, and most of them are preventable. So our aim is to prevent the preventable, that is the maternal deaths due to PPH, and this can only be achieved after the implementation of standardized guidelines and multidisciplinary programs. Next. So as Dr. Poonam discussed, that the roadmap is there and a call to action is there, that there should be no death because of PPH by 2030. This call to action was started in 2023, and from 2023 to 2025, when we saw that the implementation was not complete, then the conclave, which Dr. Poonam Goyal herself attended in detail for 3 to 5 days, this was done, conclave was done in October 2025, and the recent recommendations and guidelines were released. Next. So, the crux of the matter of PPH is in prevention and early diagnosis of PPH. Next. Prevention, we all know about the active management of third stage of labor, which is simultaneous, which is similar to the active prevention of PPH, and it ensures that there is a shorter third stage of labor, there is less blood loss, there are fewer cases of PPH. And to prevent and identify PPH, we need to give a uterotonic timely. We need to place the blood measurement tool. This is an important introduction in 2025 guidelines, where they have said that objective assessment is to be done. It has to be through calibrated parameters that we are able to diagnose, we estimate the blood loss. And again, the part of active management of third stage, that is deliver placenta with controlled cord traction, check uterine tone and massage if it is soft, check bleeding, and one has to be alert for PPH. PPH mindedness. Every doctor next should assess the high risk factors in every case, may it be in antenatal period or may in labor ward, that what are the high risk factors associated with this patient, and it should be well documented in PPH monitoring proforma. Now, to start, I'll be telling you step by step how to manage a case of normal delivery to prevent a PPH. So, we have to, after the delivery of a baby, we have to check for the second baby that it is not an undiagnosed twin pregnancy, and we have to give uterotonic within 1 minute of delivery of the baby. And this uterotonic can be oxytocin, carbetocin, or heat stable carbetocin and misoprostol. Again, carbetocin or heat stable carbetocin is the new introduction as per 2025 guidelines, and it has to be given for prevention of PPH only. We all have to have a uterotonic in our hand before birth. As far as oxytocin is concerned, it has to be given IM. If IV is not there, preferably IVF. IV, if IV line is there, it can be given as 10 international units diluted over 1 to 2 minutes. The only problem with oxytocin is it has to be refrigerated in 2 to 8 degrees centigrade, otherwise its potency decreases. Second is carbetocin and heat stable carbetocin. The difference between carbetocin and heat stable is that carbetocin plain again has to be refrigerated in 2 to 8 degrees centigrade, and heat stable need not any refrigeration. It is given 100 microgram IM or IV. If IV, then one has to administer it slowly over 1 minute. It is, as I said, it is only for prevention of PPH. Heat stable does not require any refrigeration. Next slide, please. Third, uterotonic. So there are 3 uterotonics for prevention: oxytocin, carbetocin, and misoprostol. Misoprostol, 400 to 600 microgram orally. It can be given perorally, sublingual, or per rectum, but best is to give it sublingual because absorption is better. No refrigeration is required, only it has to be protected from humidity. Now, women with high, as we have assessed the high risk factors, the women who are at higher risk of PPH, a combination of oxytocin, IM or IV, and a misoprostol can be given. Trenexa, injectable prostaglandins, or ergometrin alone or in combination with oxytocin should not be used for prevention. Again, there is a change. Previously, we were using ergometrin for prevention of PPH, but now as per 2025 guidelines, it has been excluded for prevention and it comes under escalated PPH care bundle only. So this is the difference again to be noted. Next slide. So this was the role of uterotonics. Second step is to place that as soon as the delivery is there, you have given the uterotonic, you have put the baby on the chest of the mother. You have to put a measuring tool. This measuring tool can be a calibrated drape. It can be trays with calibrated lines or other your local innovations. We have to take care that we whatever blood has come out or there are clots, it has to be swept in the measuring tool. We have to continuously check the amount of blood in the tool and their blood flow for early diagnosis. Objective measurement of blood loss is the key. So this again is a very important factor. Third, next slide please. So after uterotonic, after placing the measuring tool, it is the we are cutting the cord. The cutting of the cord is 1 to 3 minutes after the baby delivery. But if there is a heavy bleeding or the baby is not breathing well, the cord can be cut immediately. And it has to be the placenta has to be delivered by controlled cord traction by a skilled health worker after the signs of placental separation is there. What are the signs of placental separation? Gush of blood or lengthening of the cord. CCT should only be done during contractions. Never pull hard on the cord. Stop if resistance is felt to avoid tearing of the cord and uterine inversion. Stop if resistance is felt to also if there is an adherent placenta. Next, please. So now comes the fourth point. Check the tone. We have given uterotonics. We have put in the measuring tool. We have delivered the placenta and cut the cord. Now comes the check the tone of the patient uterus. And if the uterus is flabby, massage the uterus when soft. You try once you have felt it may be hard, but it may become soft again. So you have to repeatedly check the uterine tone at least every 50 minutes and assess the tone. A hard uterus feels like a forehead and a soft uterus feels like the tip of the nose. So we need to differentiate between the two. Next, uterus should be firm at midline and at the level or below the level of umbilicus. If the fundus rises, it is to the one side, it may be because of full bladder or clots inside the uterus. We need to massage, we need to encourage frequent urination, and a full bladder may slow down the uterine contraction. If need, catheter can be put in. If any time we find, as per the Dr. Poonam's new guideline for PPH loss, we have to start PPH bundle immediately. If placenta is not out and there is heavy bleeding, first start the PPH bundle and then remove the placenta manually. Next. So now we have seen the tone. Now we have to check for the bleeding. These are again the same parameters as discussed by Dr. Poonam, but one thing else also is there, that is the clinical judgment. By seeing the rate of blood loss, if it is in the gush, if it is very fast, if there is presence of risk factors and the amount of blood loss and amount of bleeding is heavy, then we can also clinically judge with our experience that it is PPH, and we can label the patient of having PPH and we can start the clinical treatment bundles. Next. So it has been discussed in detail that postmortem monitoring is mandatory every 15 minutes for the first hour, then every 30 minutes for the next 2 hours. Engage women to prevent PPH herself. Teach her how to feel the hardness of the uterus, how to massage the uterus if it is soft, and ask her to speak and tell the doctor about the bleeding if she feels that it is excessive. If after 1 hour the patient is stable and there is no bleeding, remove the blood loss measurement tool and move her to the postpartum ward. But and the woman and baby should stay together in the facility for 24 hours minimum after a normal birth. If any time we feel that there is excessive bleeding, start treatment bundle immediately. Next. Next. So the last point for previous slide, last point for PPH detection is that be alert. We have to be alert about the blood loss, about the tone, and about the flow of bleeding, that how fast the bleeding is occurring. So this is in nutshell about the management till this time. Next slide. So, if the patient is stable and there is no bleeding, excessive bleeding, then we have to check the placenta whether it is complete in the lobes, in the membrane or its part. If any time we feel that placenta is not complete, we have to manually remove the placenta. Second is the check for tear. This is in the normal patient. When the patient is not bleeding, we have to check for the completeness of the placenta. We had to check for the tears. If there is bleeding, and we have to, now, if there is bleeding, but the uterus is firm and the placenta is complete, tears are likely the cause. So we have to assess for tears. The risk of bleeding from tears increase in case of episiotomy, large baby, augmented or obstructed labor, and assisted vaginal birth. If any time again there is PPH, we have to start the PPH bundle immediately. Next. So after this everything, if there is no PPH, assess the baby, continue care for woman and baby has to be given, assess the baby, assess the woman, and record all the details on the postpartum monitoring form. So patient's pulse, BP, and a shock index has to be monitored after 15 minutes of delivery once the patient is there, irrespective of placenta has delivered or not. Next. So these are again the same lines which I am repeating again and again, so that other than the specialists who are attending this webinar, everything becomes clear to the paramedical staff, nursing staff, midwives, and PG students, that assessment of hemorrhage risk, give uterotonic blood loss measurement, deliver placenta with controlled contraction, check uterine tone, check bleeding. Once the woman is stable, check the placenta for completeness, check and repair the tears, assess and record tone, bleeding, and vital signs. Keep the blood loss monitoring tool in place for the 1 hour, and if there is excessive bleeding, then it can be kept for the 2 hours. Next slide, please. So now again a yellow. Previously what I was discussing was all in green, that go green. Now a beach ki cheese, there is something in between where there can be a problem because of this. So if placenta is not delivered, it usually delivers in 15 minutes, especially when we give timely uterotonics. If it does not deliver, feel for the uterus. If you feel that the bladder is full, catheterize and do a repeat control contraction. And if any time there is bleeding, start the PPH button. Next. Now, if previous slide, if the placenta is not yet delivered by 30 minutes, then you have to remove it manually if there is not excessive bleeding. But anytime if there is excessive bleeding, follow the PPH bundle and then remove manually. Next. So this is the whole for the treatment wise of what PPH bundle consists of. I will be dealing them with in detail one by one. Yes, next. So PPH bundle. Now, previous slide. So early diagnosis is the first step. Once you have diagnosed that it is PPH, call for help or shout for help, emergency PPH card and medication, assess for shock, communicate with the woman that what is the problem and what we are going to do with her, communicate to her companion, the health team, and establish the role of the health team, what they are supposed to do. Start the treatment bundle is set. What are these treatment bundles? These treatment bundles are a set of interventions when given together improves the total outcome. Next. So for PPH, the mnemonic for a treatment bundle is motive. M for massage the uterus. O for give oxytocin drugs. T, Trenexa. This Trenexa is now the new addition as per 2025 guidelines, though it is there since 2017-18, but now it has very importantly given the part to play in the management of PPH. IV excess of fluids, examine to find the cause of bleeding, and E also stands to escalate care. Administer all interventions, even if woman improves after only one, but we have to complete the whole set. The order does not matter, and aim to finish all interventions, these motive bundle interventions, in first 15 minutes. Next. Now, I will deal them individually. Massage the uterus. So how it helps? It causes contraction. It expels the collected blood, and it also gives us the assessment of full bladder. If full bladder, catheterize it. If alone, massage first, then move on. Oxytocin or Uterotonics, we have already given 10 units of international units of oxytocin just after the birth of the baby. Another 10 units now can be given directly or diluted in 100 to 500 ml of crystallite fluid as far as possible, or we can give it as bolus over 1 to 2 minutes. If no IV line, give oxytocin, the second dose also IM. Next. Next. Next slide. Yes. No, previous slide. Yes. So third is motive. Third is tranexamic acid. In all patients of PPH, as a part of first care bundle, give tranexamic acid 1 gram IV over 10 minutes. Foster administration can cause hypotension. Trenexa and oxytocin can be given in the same IV line, but not in the same IV bag. Do not start Trenexa if 3 hours or more since birth. If there is a contraindication or hypersensitivity to Trenexa, it should not be given, like known thromboembolic event, renal failure, or history of convulsions. Start IV. Now, the widest bore cannula which is available with you, preferably 18 gauge cannula, should be inserted. Collect blood for lab testing for hemoglobin cross-match and clotting studies, and begin infusion of crystalloid fluids like normal saline or ringer lactate. You can start second IV line with crystalloid fluids, as in one IV line oxytocin is on flow. Next. Examine and find out the cause. Motive E is for examine to find out the cause. So cause can be tone, assess for full bladder, again catheterize, but again I am emphasizing on catheterization. Look for the tissues. If there is incomplete placenta or there is incomplete placental membranes, remove it. If there is adherent placenta, suspect Acarita and continue for surgery or whatever measures to be taken. If there is a trauma in perineum or cervix, then identify and repair them. If it is an inverted uterus, replace and use the local protocols. If you suspect a uterine rupture, seek advanced care. These are the major causes of PPH after the atonic uterus. And fourth is you have to look for the coagulopathies. And for this, again, you have to collect blood for lab testing for the PTINR, prothrombin time, APTT, and platelets for fibrinogen and coagulopathy. Next. So we have discussed about the motive all, and the last E in motive is for escalate. So now you have to escalate care in spite of these if bleeding continues. And what does escalation of care means? That you have to give fast fluid, and you have to act fast. Next. Call for more help, call seniors, continue monitoring, call for anesthetist, communicate to the patient and patient's relatives, massage, catheterized, if not yet catheterized, remove clots and debris from the cervix and uterus. If the uterus is not firm, in a way similar to MRP, give a single dose of antibiotics and monitor. Next. So these three things were given by the first professional, that is massaging the uterus, catheterizing the uterus, removing the clots from the cervix. And on the second side, we have to place a second IV line, give additional uterotonics and repeat Trenexa. First Trenexa dose was the initial one. Now, with escalation of care, we are going to give repeat Trenexa and additional uterotonics, that is 20 units in 10 units in 500 ml or 20 units in 1 liter of saline. So we have given 10 units, then after that again 10 units, now 20 units in the IV fluid. Do not give more than 3 liters of IV fluids with oxytocin in 24 hours. Maximum oxytocin which can be given is 60 international units. Now comes the role of ergometrin. Ergometrin was not used as prevention, but now we can give ergometrin if there is no effect of oxytocin, 200 microgram IV or IM in 15 minutes if needed. Repeat every 4 hours up to 5 doses. Do not use either in suspected retained placenta or if there is hypertension, and it cannot be ruled out also if we are not sure that patient is hypertensive or not. Next. Third uterotonics is again for the misoprostol. And now second tranexamic use. First Trenexa we have given in the first this thing. Now second Trenexa use. If additional uterotonics and Trenexa fail, move quickly to transfer or surgery after assessing for shock. If shock, check ABC and manage. Open airways and ensure breathing. Start oxygen, access circulation, support or increase blood volume. Apply NASG, prepare for blood transfusion, and transfer immediately while still providing care. Next. So now comes the 3, that is advanced intervention. Because even after the repeat dose of Trenexa and more uterotonics, patient is still bleeding, then we have to do 2 bimanual compressions are there, that is aortic and bimanual uterine compression, and 2 devices, that is intrauterine balloon tamponade and NASG. These all PPH bundle minded, it is for atonic PPH. We are focusing atonic PPH, which is the major cause of bleeding. Next. So this is the method of, so in advanced care, we have to think about the blood transfusion. Blood transfusion, if hemoglobin is less than 7, more bleeding is there, then repair of the vaginal and cervical tears, intrauterine balloon, and bimanual uterine massage. Next. These are the methods how to do the bimanual uterine massage. Put one hand in the anterior vaginal fornix and one hand behind the uterine fundus. Squeeze the uterus for 5 minutes. If after 5 minutes, slowly remove your hand, and if bleeding restart, resume compression. If no bleeding, continue on IV infusion and oxytocin. Now, again, a very important point is compression of abdominal aorta. Apply downward pressure with closed fist over abdominal aorta through abdominal wall, just above umbilicus and slightly to the patient's left. With other hand, palpate the femoral pulse to check adequacy of compression. Pulse is if the femoral pulse is palpable, there is inadequate pressure, so apply more pressure. Maintain compression until bleeding is controlled or until it reaches the operation theater. Next. Now insert uterine balloon tamponade. Before this, consider aortic compression. Check and remove any retained clots. Ensure deep tears. Ensure that the deep tears are already repaired. Ensure that the bladder is empty. Monitor blood loss, and if still bleeding after 15 minutes of balloon tamponade, seek surgical help. Next. Repair deep tears. Next. NASG, as Dr. Poonam has discussed in detail, it compresses the lower body and is a device which can which is stretchable neoprene, and it forces blood to the heart, lungs, and brain to prevent shock or to stabilize women in shock. NASG does not treat PPH but gives time to seek treatment. Next. Next. Now, very important point, referral and transfer. Once you know that your facility is not well equipped to manage the patient further and the bleeding is continuing, you have to think about the timely referral and transfer, and what are the indications. Continued heavy bleeding, need for blood transfusion, need for surgical intervention, uterine atony not controlled by uterotonics and uterine massage, suspected trauma beyond repair here, massive hemorrhage with signs of shock, failure of or less invasive temporizing measures, and inability to place or maintain them safely like UBT. Next. Follow the stabilize, temporize, and transfer principle, early recognition, immediate action, no delay in transport, stabilize before shifting, 2 wide bore IV lines, crystalloids, uterotonics, Trenexa, uterine massage, control bleeding by manual compression by tamponade. Referral note must include vitals, estimated blood loss, drugs given, IV lines, interventions, inform a receiving center, and transfer with skilled staff and continuous monitoring. Next. I'll be failing in my duty if I don't talk about 5G referral system for PPH, which is now available in India. The 5G are for GPS tracking, that is real-time ambulance position plus shortest route. Geotagged facilities finds nearest center with OBG plus blood bank facility. Guidelines based decision tool, app prompts to ensure stabilization before referral. Gigabit connectivity, live video consult between PHC, CSC, and specialists during resuscitation, and golden hour dashboard alerts tertiary center while patient is in transit. The information is transferred to them. Next. So 4, last of all, when all these methods fail, address the cause, do surgical interventions, stepwise devascularization, internal iliac ligation, uterine compression sutures, emergency peripartum hysterectomy, or decision-making factors. Next. So this is my last 2 slides, that prevention of PPH, again, risk factor, uterotonic, measurement of blood loss, CCT, assessment of tone, bleeding, alert, monitoring, diagnosis on the basis of blood loss, management based on the motive, escalate the management when there is a still bleeding, advanced interventions, 2 methods by 2 compressions and 2 devices, and surgical intervention, compression sutures, stepwise devascularization, and all. Next. Next. Again, documentation and briefing is very important. Important to record sequence of events, time and sequence of administration of pharmacological agents, surgical intervention, condition of mother throughout the PPH process. Next. Next. So provide postpartum care, which is very important, and Patient has to be continued on oxytocin drip, increase post-operative hydration, decrease stepwise oxygen if patient was in shock, repeat lab test, and gradually increase physical activity. Next. At the time of discharge, ensure that woman's record is complete. Repeat lab test for hemoglobin. Ensure normal vital signs. Continue or begin antibiotics as per protocol. Provide routine postpartum care and counsel the risk of PPH in future and importance of a facility birth. Plan follow-up for care for 48 hours, 10 days, and 6 weeks. Next. Take home message: prevention is the backbone. Identify high risk factors, antenatal optimization by treating anemia, monitoring BP, and birth preparedness. Earlier diagnosis saves life. Recognizing early warning signs. Objective measurement of blood loss is now mandatory. Pulse, BP, and shock index has to be calculated. Use the WHO motive bundle care. Ensure no step is missed. Next. Golden hour concept is there. Access the cause immediately. Rapid escalation and decision making pathways. Surgical readiness. Early action improves survival. Team communication and simulation drills are mandatory. And respectful maternity care during emergency is to be there. Thank you. Next. So, thanks a lot for giving me this time so that I could explain the things stepwise. Now I will ask for the comments of my experts, Dr. Asmita.
Hi, a very good afternoon, and I think I must thank both the speakers for excellent presentation.
Some connectivity problem, Dr. Asmita. Dr.
Guideline
Asmita,
covers is the identifier. Then what are this? Am I audible, Dr. Sangeeta?
there is some connection problem, connectivity problem, network.
Okay. And for these guidelines to be useful in achieving our objectives of reducing the matter in health outcomes and reducing the maternal mortality, it's very important that everyone who is dealing with a pregnant patient and conducting the delivery or is present at the time of delivery is aware of these protocols. These protocols are widely disseminated to all healthcare workers, and they are executed or implemented properly, and execution is monitored also with the help of audits. So to achieve our PPH roadmap of elimination of PPH mortality by 2030, we all have to be come together and make aware and disseminate these guidelines. All healthcare workers are to be sort of trained in utilizing them and ensure that it's executed without any zero tolerance to non-compliance to these protocols. Thank you, Dr. Sangeeta, Dr. Poonam, for an excellent presentation. Thank you.
Dr. Asmita, my question from you is that what exactly is the role of Mithazine? We are so used to using ergometrin, and how do you recommend that how it should be used?
Yeah, so if we look at the evidence regarding the efficacy of an methargine in controlling postpartum hemorrhage, it's effective in controlling postpartum hemorrhage as much as oxytocin, but it has got some serious side effects. So that is the reason we should be aware of contraindications for methargine, and it is not recommended for prevention of a postpartum
Yes.
hemorrhage. But if woman develops PPH, it should be used in treatment of PPH unless there is specific contraindication like a severe hypertension or a myocardial infarction in past or some morbidities. It's an effective drug to control PPH, but because of side effects, we don't recommend it for prevention. It's beneficial in treatment if not contraindicated.
So I think the practice of using Mithazine in prevention of PPH should be abandoned, and we all should now
Yes.
follow the practice to use it as a tool of management That too in escalation of care, when the bleeding is not controlled after the repeat dose of oxytocin and Trenexa, then we should come for methergine.
Yes,
So
absolutely.
I really wanted to know about you. Yes, Dr. Archana. Now I will ask your comments about the newer guidelines.
Thank you, Dr. Sangeeta. Actually, whatever we learn, and it should be in our daily routine practices also,
Yes.
because simply my advice is awareness of PPH is much more important. Everybody should know that even a single normal pregnancy can go to the PPH, not only the high risk pregnancy. So one has to be very much ready, and the simple learning and is very very important just to save mothers. And we all know the clinical judgment. Want to tell few things. One thing is a clinical judgment is so much important and helpful, like the shock index, number one. Number two, waiting period. We should remember the waiting period should be minimized. If whether you are working for a mechanical, waiting for mechanical or uterine balloon, whatever you want to do within a particular set of time, so that and you consult another consultant also, and for the escalation purpose, because the time saved is much more important. And then second is what I say कि believe in basics. आपका सबसे पहले like PPH का management का जो basic concept है, all of us should know that first is that early emergency response system. So in that comes the AMTSL and the call for help, and then start the PPH bundles, because PPH bundle is a set of pattern of things to we should be know and to do. And early diagnosis, management, and referral, these three things are very very basics and important. But for management, this first response PPH bundle is one thing where we do, like you told, massage and IV fluids and this tranexamic acid. And then the supportive system. What supportive system we need to do along with the medical management is simply all this compression, bimanual compression, and this bladder should be empty also. And then this refractory, what happens when the patient is not being managed, then even then there are certain supportive management, and before jumping to the hysterectomy and or the internal iliac artery ligation, this compression, uterine balloon, and anti-shock garments, this is they comes under the. So this PPH bundle ka I've seen so many time patient we are not even a habit of understanding what is PPH bundle. So many doctors ask what is PPH bundle. So this does AMTSL comes under the PPH bundle? So no, AMTSL is the emergency response, and then call for help, then start the PPH bundle. So thank you, and it was very very nice. Everything, every word you said is something important, and including aortic compression. I want to say, if you don't have anything, then call for help to give the aortic compression also, and with the aortic compression, shift the patient to the labor room or OT or ambulance also, and with the NASG. These things are very very simple but very important. Thank
Dr.
you.
Archana, my one question from you is what tool you are using for objective measurement of blood loss? What tool you are using?
Madam, as such, I want to just say that simply that drape is a very important tool is to measure, because objective measurement is say gone are the days when we were believing the sponges and that photos and chart ki this much is 100 ml and this much is 50 ml and this amount of gauze is there. So that is drape is being used here, and the simple to in I mean it's very simple to make it. Even if you don't have that, you just take any plastic and just clip it and like this and move it like this, and they move. And I can show you how they make this drape easily by self-made, make in India types. And but otherwise in now we have started using that drape.
Okay, so you are satisfied with the this drape system as far as assessment of blood, because this is the most important part. हमको पता ही नहीं चल रहा कि पेशेंट का ब्लड लॉस कितना हो गया, और हम कहते हैं कि अभी तो कुछ नहीं है, माइट. That's why the reporting of PPH is not there. Under reporting of PPH is there.
Yes, ma'am,
Because
very true, ma'am. Even the Ma'am, na, like if you're with your talk, people will understand what is debriefing. The people don't even sometimes understand the meaning. Dr. Asmita is from a big medical college setup. She knows that this debriefing is so much important, and private practitioners, they avoid certain things. So this even understanding the debriefing is also very, very
So
important.
that's
And
why
what
I
is,
told every step in detail, though it
yes.
might have been quite this thing,
No,
specialists
no,
know
you told,
everything.
yes, your talk was perfect. So in that debriefing, you said, because in management sometimes we just get entangled in PPH bundles and all, but somehow this is ki what happened exactly and how can we improve that from the next patient, because we all learn from our clinical experiences only.
So you think that the measuring from the tool of drape is adequate for the right assessment
Ma'am,
of
it
blood
is not only educate, it is quite helpful
pressure?
because along with that clinical tool, that shock index, because sometimes even with 100 ml of blood loss, patient gets hemodynamically
Yeah.
unstable. Dr. Smita will
So
say.
warning signs
Then we
also.
don't wait for 500 ml or 300 ml.
Dr. Shashi Lata, our PPH lady. Now I want a very to the point comments from her as far as the management of advanced management of PPH.
Thank you so much, Dr. Sangeeta ma'am, Dr. Poonam Goyal. It was an excellent presentation by both of you, covering every point of PPH management. I will just emphasize a few things. First is, we should keep in our mind, we should think like this, that death due to PPH is preventable. Second, it is not a matter of 1 minute. 1 minute has 60 seconds. And each and every second for management of PPH is very important. तो उस seconds को कैसे करेंगे? We have to be well prepared. So the concept of PPH toolkit must be there. We should always be prepared. That toolkit will contain everything required for the management of PPH, including the cannula, balloon, everything. Suppose the balloon has been used in one patient, then we must keep another balloon prepared so that not even a single second is wasted. Regarding IV cannula, I would like to say that we have to rush fluids around 2 liters in 15 to 20 minutes. So it's better that we use at least gray cannula, whose blood flow is 180 ml per minute. Then the role of AMTSL. Active management of third stage of labor must be done. It should never be forgotten. Because only single AMTSL prevents the onset of PPH by 50%. तो हमने PPH से 50% दे तो वहीं कम कर दी the moment we are using AMTSL. Then regarding new additions and deletions in the management of uterotonics, as all of you have said, that methergine is no more nowadays used as a prevention. So यहाँ मैं एक बात बताना चाहूँगी, remember, besides this, remember 2 C's. Carboprost used only for management, and carbetocin used only for prophylaxis, not for treatment. So this is how we can remember. Then misoprostol. Misoprostol can be used for prophylaxis and for treatment both. But remember one thing, that if we have already used misoprostol for prophylaxis or postpartum hemorrhage, then it will not work for management. There we have to use some other medicine. Then comes the non-uterotonic, that is tranexamic acid. This is an addition. It has to be used in every case of postpartum hemorrhage, irrespective of the type of delivery, whether abdominal or vaginal, or irrespective of the cause of PPH, whether traumatic or atonic, whatever. And it must be given within 3 hours. 1 gram, and it can be repeated if the bleeding has recurred or continues in 24 hours. Then about few words about NASG. Madam, you have beautifully spoken about this, that it is very important. It delays, it seeks time, it gives time. It's a life-saving garment, and everybody must practice using this NASG. In Tamil Nadu, the ambulance also carry NASG, and even the drivers know. So I think in Delhi and other states also, where it is still not in practice, the use of NASG must be taught to everyone so that we can utilize maximum. Then coming to conservative methods, breast sutures. When we actually want to do or want to perform breast sutures in the OT, then we keep asking, "Arey bhai, tum batao step, tum batao step." So we can keep a laminated diagram of Bill or Heman suture in every maternity OT. So that will save time. Then internal iliac artery ligation. When we were doing MD, nobody taught us how to perform an internal iliac artery ligation, but it is the time. Even the FIGO in 2022 guidelines says that every obstetrician must be acquainted with the technique of internal iliac artery ligation. So I say that now we are getting epidemic of placenta accreta spectrum disorder, and every obstetrician must learn internal iliac artery ligation, and it should be a part of PG curriculum. So that is very important. And last is hysterectomy. So, as we have already said, when the patient is in shock, the role of conservative methods is almost nil. We have to perform hysterectomy. And the decision for hysterectomy should be taken sooner rather than later. And absolutely, there is no point in saving the uterus and losing the mother. So it must be done timely and just when it is required. So
Thank you,
these are
Dr.
the
Shashi.
comments I
Dr.
wanted to make.
Asmita, I would like to have your comment regarding the role of hysterectomy because you have dealt with so many emergencies and so what do I want your expert comment regarding when the role of hysterectomy comes in the picture?
I Hysterectomy is a very important tool in the management of PPH to save mother's life. And as Dr. Shashi rightly pointed out, we follow the protocol, go systematically. The most critical indicator as to when to proceed with an hysterectomy depends on how the mother's hemodynamic condition and the amount of PPH that is happening. If patient is continuing to trickle, not responding to your treatment, at every step, your conservative primary first line protocol, then we start with the second line B Lynch, compression sutures, then internal stepwise devascularization. Everything has to be done within a time span and don't wait indefinitely. It should not be a protracted thing. Everything has to be time bound, keeping a very keen watch on the patient's hemodynamics. If our hemodynamics improving, yes, we can wait for some more time. But hemodynamics, if they are going down, because if patient bleeds a lot and she ends up with an DIC, then probably we are nowhere, and we can't even save mother at that point of time, and even proceed with hysterectomy. So time management is very, very critical in PPH, and that we have to keep in mind, that we should not hesitate on proceeding with an hysterectomy if patient is in shock.
So I think the time is also over and the discussion of PPH never ends, but we will be able to end the maternal death by PPH by 2030. And if we keep on doing such revising webinars about PPH, I think every step will be there in our mind, and our healthcare professionals which are really at the grassroots level, they are dealing with the normal deliveries and the PPH condition. I think we'll be able to achieve the target by 2030. And thank you, Dr. Poonam, and my experts, Dr. Asmita, Dr. Shashi, and Dr. Archana, for sparing your valuable time and the platform given to us, Ada. And please thank you all for giving us such a nice platform. Thank you.
Thank you. Thank you.
It was a very nice, useful webinar.
Yes,
Yes.
yes.
Yes, Ada, your final
Thank you.
words.
Yeah, thank you so much, Dr. Sangeeta ma'am, for wonderfully moderating today's session in such short notice. So, your guidance and smooth coordination truly made this session meaningful and impactful. So, we also want to take a moment to acknowledge Dr. Sharda Jain ma'am. We truly missed your presence today. We completely understand that you could not join due to an emergency. So we hope everything is well, and we look forward to having you with us in our upcoming sessions also. Heartfelt thank you to all our esteemed speaker and experts for such valuable knowledge on bleeding after birth, the new rules of prevention, early detection, and smart management. On behalf of IGCP, I extend my gratitude to all participants for joining us this evening. Your engagement and constant support inspire us to keep bringing enriching academic programs. Wishing everyone a safe, healthy, and peaceful evening ahead. Thank you. Good evening.
Thank you. Thank you so
Thank
much.
you,
Thank
ma'am.
you.
Thank you.
Thank you. Thank you.